Welcome to Becker's CEO and CFO Virtual Forum and the featured session, Strategic Cost Transformation in Healthcare, using activity-based costing to understand and improve operating margin. On behalf of Becker's Healthcare, thank you so much for joining us today. Before I introduce today's speaker, I'd like to first go over some quick housekeeping details. You can submit any questions throughout today's session in the Q&A box on your dashboard. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's session to access that recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. You'll also find a few other engagement tools on your dashboard. Be sure to check out our resources section and fill out our event survey. With that, I am pleased to introduce our speaker today, Rob DiMiche, retired Executive Vice President and Chief Financial Officer of UPMC, now serving as Strategic Advisor for Health Catalyst, as well as a board member for Waystar. Rob served as Executive Vice President and Chief Financial Officer of UPMC, a $20 billion integrated healthcare delivery and finance system that spans the full spectrum of care with its network of academic, community, and specialty hospitals, doctors' offices, and outpatient sites, insurance services, and international and commercial operations. Rob, thank you so much for being here, and I'll turn the floor over to you.
Thank you, and good morning, everybody. The first slide I want to start off with is really what I call the why slide. So we're going to talk more today about activity-based cost accounting, and we're going to talk about improving operations and operating margins, but the why is on this page. So to spend some time here, what I call is the balkanization of provider revenue. So what do I mean by that? I mean, it's the disorderly or unpredictable fragmentation of provider revenues as you know them today. And there are 5 forces that I've laid out here that I want to walk through, but the end game is that I want you to consider is, will there be a permanent impact on revenue and growth? I've seen some presentations in the last few days. The JP Morgan conference was last week. Others have presented their full year results, and many are predicting a return to normal, if you will, and a revisiting of revenues to normal levels either later in 21 or perhaps in 22. And I want to call that theory into question. And these 5 drivers are the reason why. So in the middle, you see the impact of COVID-19 and just the specific impact, but also the impact on the economy. So there is no doubt that volumes have been impacted and continue to be impacted by COVID. The elective procedures have reduced. The use of the ED has gone down. Use of urgent care has been impacted in many cases as people are starting to use telehealth. There's a question around the role of telehealth. It was used as a way in March and April to actually see patients. There was a surge in its utilization, but that has gone down since then. So the question is, in the long term, what will be the actual strategic integration of telehealth into the everyday operations of a hospital? And basically, what will that do to the footprint that you have of your healthcare system from the utilization of telehealth? There is no doubt that the impact on the economy has been significant. We've already seen significant changes in payer mix. There are lower numbers of insured employees and therefore patients. And so we've seen an increase in ACA patients, in Medicaid patients, and in self-pay patients. So the question is if and when that payer mix will recover. It has also led to what we think will be changes in plan design. So the whole idea of narrow networks and changes in plan design, they're very difficult to implement in a robust economy. Employers are fighting for great employees. People are moving, leaving for other opportunities. Due to COVID, there has been fewer movement. There's been high unemployment. In many cases, people are grateful to be employed and certainly happy to have healthcare coverage. So to the extent that employers are willing to make changes to their plans, introducing higher co-insurance and narrow networks, that also is going to have an impact on your healthcare volumes. To the left, you see the impact of the insurers, and I think this is probably going to be the most significant. Insurers are thriving right now. The lower utilization on the provider side has led to improved economics on the insurer side. And so they are now going about vertical integration. They are doing what I call insourcing healthcare. They are becoming providers themselves in addition to insurers. So in addition to doing that, they are certainly attacking Medicare Advantage. And this is where there's a significant utilization by patients, older citizens, older members, and higher in terms of utilization just for invasive procedures, but also chronic conditions. So this is a real area of attack for the insurers. And so whether they're attacking it through vertical integration, owning providers, or through affiliating with third parties. And there's some great examples right now, whether it's somebody like Oak Street Health, whether it's somebody like CVS with Health Hubs, One Medical, KenMed, they are all after that Medicare Advantage dollar, trying to decrease utilization and spend. And we've seen instances where they are decreasing elective procedures between 30 and 50%. So this is a real threat to volumes into the future. If you go to the right on the commercial book of business, certainly price transparency is in the news. It was effective January 1. There are 70 prescribed services that are required to be disclosed by you. I don't know that that's going to have much impact or use to consumers, but it will be very interesting and helpful to brokers, to insurers, and to employers. And so what that will reveal, that price transparency, is the significant variation that we have with commercial pricing. It will also reveal what I call the irrational pricing that exists today. And so that is certainly going to pressure your price points for your outpatient business, for your elective procedures, and for your high-priced clinical interventions. And so there's also an opportunity to potentially raise prices on high-end services where you are considered an expert, you have a high level of efficacy, you are a center of excellence, but it will require rational pricing as opposed to irrational pricing. And so you will need to understand your costs and where your profitability is by patient, by procedure, by service line, very important. And then certainly the impact of CMS. And we understand that the Biden administration, very much like the Obama administration, had implemented bundles and value-based care, and we expect to see more of that. Also increased scrutiny of M&A activity. So if your strategy around growth was through vertical growth and M&A, there's certainly going to be great antitrust scrutiny, or at least more than there's been in the past. So the question you have to ask, is there a permanent impact on the revenue of your organization? Will you ever achieve those levels that you had pre-COVID and on your ongoing growth? So again, this is a slide which just shows the change from fee-for-service revenue to capitated, value-based pay-for-performance. And again, to take on risk, you need to understand your costs, and they need to be understood in an accurate manner. So very important to have great costing information to take on risk. How did we end up with an activity-based costing system? So my background, and we started this at UPMC before we sold the technology to Health Catalyst, but my background was in manufacturing, and I worked for General Electric, and we utilized Six Sigma, where we scrutinized variation, process variation, engineering variation. Any kind of change was considered the enemy of quality, and we scrutinized every change in a component was scrutinized. But you take a comparison to healthcare and you think of clinical pathways, and we have tremendous variation in the treatment of our loved ones. So what is more important, the manufacturing of a device, of a locomotive, or the healthcare that we deliver every day? So I think that variation is unacceptable, certainly in manufacturing, and it's even more unacceptable in healthcare. This wasn't always the case in terms of really caring about costs. We came from a fee-for-service environment where the more you did, the more cost that you incurred, the more revenue that you could create, the more utilization. So fee-for-service actually drives up costs. And we did not have access to, when these cost accounting systems were developed, the electronic medical record. And why is that relevant? Because the EMR has a wealth of information that can be utilized to understand consumption. And consumption actually is what drives costs in healthcare. So these old systems that may be used by your system today are based on an outdated model. They did not have the benefit of an EMR. And so they're not really relevant to be utilized in modern healthcare and modern finance. So this page I call Finance Mythology around costing. And it's very important to understand. And I would challenge you, any CFOs that are watching this, or any operators or CEOs, to talk to your CFOs and propose these myths to them. And I will debunk each of them. And the first myth is that we already do cost accounting. We already measure productivity. And my somewhat cynical response is that you probably don't. Because right now you're measuring at an RVU estimate basis or an allocation or on a ratio of cost to charges. Highly inaccurate and really is not respected or able to be utilized with physicians effectively because of that lack of credibility. So I'm saying you probably don't have an accurate or a usable cost accounting system. The second myth is that activity-based costing is too complex to implement or to maintain. And the reality is it's actually not. It is far easier to implement and to maintain than RVU-based or RCC-based cost accounting. And the reason for that, again, is that there is a wealth of information available right in front of you from your EMR. And then the third mythology is that, hey, we already are doing great financial analysis and we're already providing great operation support. And my response to that is that you can actually do much better. There is information that you can utilize to more accurately understand your costs and your areas of profitability than you are using or utilizing today. So this page is what I've attempted as a very simple explanation or definition of activity-based costing. But before I read this with you, I want to talk about why it matters and the way that healthcare works today in terms of costing. So nearly all hospitals and health systems completely separate the activity of their physicians on one side with their hospitals on the other side. So they have a physician P&L, and on that physician P&L is generally the costs involved with physicians, so their salaries, their support staff. It could be related to their outpatient clinics and their CPT and outpatient activity, and that's the physician P&L. Over to the other side is the hospital P&L, and there's really no connection between the two of these two things, and that's where we have a problem, because they need to be connected, because the people making the decisions that are impacting and driving that hospital P&L are the physicians, but their activities are never influenced or impacted on that hospital P&L. Instead, we have large pools of cost on a hospital P&L that we call overhead or indirect clinical costs. And we use allocations and we use estimates to determine the profitability and how we should pool those costs into a particular service line or how they should be attributed to a physician. And that's the old way of thinking about those things. And what it does, it creates little or no accountability. So Economics 101 says that nothing is free. And it says that cost has to have a major impact on consumption. So think about just decisions that you make as a consumer today. Let's say you're putting an addition on your house. You want to shop for value. You may not select the most expensive materials, but at the same time, you may not want to buy the least expensive materials either. You're going to make informed decisions around quality. And so it could be a combination of high-priced goods and lower-priced goods, but at the end of the day, it's what's the impact on whether it's the aesthetics or the efficacy of a procedure in this case. But we want our physicians to be able to make value-based decisions, just like we make value-based decisions with our consumer purchases. So think about things like the utilization of an OR. or the cost of length of stay, or the amount of imaging or labs that get ordered. Today, in many systems, these are all free. The physician makes a decision and the hospital pays for it. So we want something different. So the definition that I use for activity-based costing, if you want to think about it as a simple way, and just the word activity-based costing tends to scare some people, but activity-based costing in very simple terms connects the actions and decisions of clinicians to the actual cost of each action and decision. Now in the middle there we put in that it relates to the consumption of finite resources, because that's the thing. These are not endless resources. These are finite resources, and we want our physicians who are making these decisions in the hospitals to connect the actions and decisions that they make to their actual cost. And the takeaway is that we want our physicians to know that actions have cost consequences. And our physicians want to be good stewards of those resources, but they have to actually understand what they're consuming and what those resources actually cost. And so when we're using Chorus, the Health Catalyst tool, and we're using activity-based costing, we want them to understand how their actions impact not only the entire triple aim. So it's not only the health that they're creating and maintaining, it's not only the patient experience, but it's also the cost of their actions as well. And so all of these three things, the triple aim, you need activity-based costing to be able to fully meet those standards. So activity-based costing is systemic, it's repeatable. So we have costing information available through Chorus 2 days after the financial close. 2 days. It's systemic, it's repeatable. It isn't an initiative, it isn't an analysis. You have costing data, you have service line financials 2 days after your financial close. It identifies physician variation. The physicians actually recognize their cost profile. This is about the consumption of resources and not the allocation of resources. And this is all anchored into either the general ledger or the clinical systems or the EHR. And you're talking now about the total cost of nursing, the total cost of your operating rooms, and your clinical compensation and how those resources are being consumed. So this is just a visual, and this is supposed to represent a super collider of clinical data from your EMR and your financial data from your general ledger. And so when you bring these two things together, you create these subatomic particles of analytics and information to help you make better operational and financial decisions. So how does it work? It's actually very simple. We use the general ledger and the EMR to find the actual direct costs. These are things that relate directly to the patient, such as drugs and supply costs and blood. We pull those out, and what are left are indirect clinical costs. And we then use activity drivers to understand the consumption of these indirect clinical costs, such as the actual minutes you've spent in the operating room, the time that you were on the MR machine, the length of stay for an inpatient stay. And that helps to define the actual consumption of the resources related to those activities. So a typical hospital P&L statement, just to illustrate the importance of this, and I'll start at the top. Of course, you have the revenue, you have multiple hospitals. You have the direct supplies, such as supplies, blood, and drugs. But in reality, this only represents about 30% of the total clinical costs. The majority of clinical costs are in this next area below, which are indirect or service center costs. So things like surgical services, nursing, imaging, labs. These are the majority of where the costs are basically housed in a hospital system. So there are systems today where either cost systems where either these are all allocated, or some are starting to utilize costing of just direct supplies. But the big miss here is the majority of your costs are in your indirect clinical costs. So you need a system that can accurately understand the consumption of those indirect clinical costs and also understand them across various hospitals. So this is an example of what I call sort of the patient mall. And the point is that we can have 3 patients, or 3 physicians for that matter, that are having the same procedure done, And that same procedure is done with 3 very different pathways. So they may utilize different indirect clinical areas, and they may consume things in those indirect clinical areas very differently. So significant physician variation from patient to patient for the same procedure. This is the same actual diagram with a little more detail. So they may come in through the emergency room and then go through the hospital and inpatient stay. They may be admitted as a result of a referral from their primary care physician or from a specialist, but they also follow through these indirect clinical areas, and they're consuming surgical services and interventional and diagnostic services. So they're making this journey through the clinical mall, if you will, and consuming resources, indirect clinical resources. And there has to be an accounting and there has to be a tracking of those resources. So the traditional view doesn't do that. It shows a traditional P&L with salaries and other costs, purchase services, supplies. What we're looking for is what I'll call a horizontal look and a service center look. So we want to actually understand. So again, if you look at this slide, at the top, we're actually saying, yes, we have patient revenue, but we're not looking at it within the 4 walls of a hospital. We're looking at it by a service line, where we may want to look at it inside of that service line by specific physicians and how they're performing within a service line, or individual patients, or individual procedures. How profitable are individual procedures? So this is the methodology activity-based costing allows. So we want to look at those in the middle where it says service center costs. And these are the indirect clinical costs that I mentioned. And so, yes, we may know the total cost of our imaging department, the total cost of our laboratory, the total cost of our operating rooms. But where are the resources actually being consumed? Which service lines are consuming those resources? Which physicians are consuming these resources? Activity-based costing allows you to understand through the direct drivers of the activity. And again, it could be the minutes in the MR machine. It could be the actual time in, room out with surgical services, the actual length of stay from admission to discharge. We understand the actual consumption of those resources. And so we are able to do P&Ls, what I call in a horizontal manner. And this is repeatable and systemic. So this enables service line reporting that other kinds of costing does not allow, at least accurately, because the largest portion in the middle, the service center costs, are inaccurate through other methodologies. They're estimates, they're allocations, and they're not to be believed. And they certainly don't have credibility with physicians. So this is another slide that shows activity-based costing shows physician variation. So we're able to see, and this is a comparison of a handful of physicians for a specific DRG, and you see specific and significant variation from physician to physician. This is an opportunity not just to improve on cost, but also on quality. There has to be a best practice. We want to eliminate variation and standardize around pathways. And this tool allows us to do it by showing us this physician variation, which is hiding in plain sight. So the next example I want to show you, and this is I think a great example of the 2 points that I made, which are, first off, that there's a significant amount of indirect clinical cost. And then secondly, there's a significant amount of physician variation. So this is an illustration of a lumbar spinal fusion. This shows 852 cases. So I'm going to show you 2 things here, as I said. First, and this is a surgical intervention versus a medical intervention. So for this, we see that the supplies, blood, and drugs are about 54% of the total cost, or $9,950. To the far right is the total cost on average for the 852 procedures of $18,220. However, the indirect clinical costs are nearly half, or 46%. So the service center costs, the indirect costs matter. You need to understand the consumption of those resources because they are significant. And your mix is certainly not primarily surgical. There's a large book of business, especially with COVID, of medical admissions. So we need to understand service center costs. The second point is you can see significant physician variation. So if you look at the bottom, even though the average was $9,950 for direct costs, we see variation anywhere between 45% of that 9,950 or 162% of that 9,950. So there's significant variation. On the service center side, again, you see variation in the OR time between 66 and 161%. In the nursing costs, 53 to 203%. So the indirects down at the bottom of 8,270, there is variation between 67% of that average and 184%. And yes, there are a few outliers there, but if you were to look at this in a sort of a box and whiskers, you'd see that there is significant variation even within the box analysis of this. So 2 points, significant variation, which is an opportunity to improve cost and quality, but also the significance of service center of indirect clinical costs on the total cost of a procedure. So that gets us to some strategies to employ to improve your operating margin. So this first group I call the tactical types of cost reduction. So these are things that people are doing today. Integration, and there are still opportunities, and there are still systems that have not fully integrated their back office, whether that's HR, whether that is IT, whether that is your patient access. There are multiple opportunities, and many of them have been attacked now because of COVID, where people are going back to try to find additional dollars through integration. But again, that last mile is still available. Centralization, you will see, even if you've integrated, in some cases, shadow organizations, there's creep and additional people are hired. So these are opportunities to go back and take another bite at the apple with integration and centralization. Setting cost reduction targets, that still works. That's still a strategy to be employed. But I would argue that after years of cost reduction, you start to have diminishing returns around that setting of targets. Something that we've done in the past is what I'll call executive leadership consolidation. And this is where we were taking the actual salary of different executives and dividing it by the number of direct reports. And you get what I'll call kind of a cost of leadership, the cost of the number of people that are being engaged or led by that particular executive. And that can lead to some interesting analytics and discussion around whether or not your organization has become top heavy. Purchase services is always an opportunity, but I'm going to show you some new opportunities through activity-based costing. And then the last three are really around the revenue cycle. And that is an area that continues to be, and I think will always have some slack and opportunity for you to improve patient access. And those are opportunities to increase volume and revenues by making your system more accessible, by keeping volumes within inside of your system instead of leaking out to independent physicians. And then just revenue cycle improvements. How can you better capture, charge, and collect on the revenue that you have earned? What activity-based costing does, however, is it enables some strategic cost reduction opportunities. And what do I mean by that? If we can begin to look horizontally, and we can begin to understand consumption, and we can begin to connect the physician activity and decisions to the hospital P&L, we now can make the physicians accountable. So we can create, and I would advise you to create, service line P&Ls for orthopedics, for cardiology, for cancer, for pediatrics, so that you are understanding the financial performance, not of just the hospital, not of just your physician division, but create these new P&Ls, if you will, if you haven't done this yet. And these are, again, systemic and repeatable every month, every quarter, of service lines where you're combining the physician activity, the physician decision-making, and holding the physician executives in the departments accountable for their activities. So what this does, this now brings supply costs, takes them out of the hospital P&L and into the service line P&L. So the physicians now are accountable for their supply costs. And what ends up happening, and I use the word supply cost activation, is that we were giving physicians credit, if you will, for reducing supply costs. In the past, they would do it because, yes, they worked for the hospital, they were good corporate citizens, and they wanted to do the right thing. But if they're faced with a target that they have to hit in their area for cost reduction, and they can achieve that target through supply cost reduction, as opposed to reducing staff, reducing other physicians, they're going to be much more engaged with creative supply chain activities, whether that is supplier standardization, whether that's moving from 5 implant vendors to 3 or 2 vendors. It's amazed the level of activation you get when the physicians get credit for the supply cost reduction activities. And I'm talking multi-million-dollar opportunities by doing this. So this is one of the biggest benefits of service line management. It creates new integration opportunities. So if you're looking at your orthopedics program or your cardiology program, it allows you to create centers of excellence that you can actually track financially. And you can see there is significant overlap in many cases around locations, the program costs, the quality of those various programs. And are you geographically positioned in your catchment area? Because in many cases, hospitals acquired inpatient and outpatient locations through acquisition or affiliation, and they're not always constructed or laid out in something that makes sense in terms of population health, geography, or something as simple as the transportation accessibility and the transportation network. So this provides opportunities to not only actually close facilities and close programs that may be redundant, but also open new programs where there's opportunities for strategic growth. From a purchase services standpoint, you can now look horizontally, not just within the 4 walls of a hospital, but you can look at the purchase services and the spend that is incurring across your entire system. It is amazing to see the number of different vendors that you may find providing the same types of services. So one example I can use is elevator maintenance and repairs. I had an example where we had 5 or 6 vendors that were caring for and providing maintenance for our elevators in our hospitals. We were able to consolidate that, move down to one vendor, and again, realize not only the benefits of the best service provider for that particular service, but also leverage volume to get a better price point and save costs. So this opportunity is available in every category of purchase services and spend. Physician APP integration. So we talk about understanding the cost of an RVU. So we don't want to measure just, are we actually in a fee-for-service world generating RVUs, but what's the cost of the RVU? And is the RVU being generated by a physician who maybe is practicing at the bottom of their license, when we have an APP who may be able to do some or all of those services acting at the top of their license? So by tracking the cost of an RVU, this provides us visibility and an opportunity to understand how we can optimize the delivery of that RVU and do it in a cost optimal manner. And so one of the ways to do this is to create a salary cap, if you will, for a particular department to say, this is the amount of money we have to spend, and you decide whether we're going to spend it on this level of specialist or is a better complement of APPs able to deliver those same services with the same or better quality, the same or better customer service, but at a lower price point. Clinical practice variation, I say, is hiding in plain sight in many instances. This is one of the best and maybe only the only way to identify practice variation in terms of manifesting itself in the cost of a particular procedure or the cost of your different physicians and how much variation there really is from them doing many of the same exact things. And then also what I call true productivity, which is connecting cost with volume. And so this is what I call setting cost per targets. And on this slide, we show some examples of what I call true cost productivity. And it's not about hours, and it's not about measuring nursing hours, because nursing hours are used as a proxy for cost and a proxy for productivity. I want to use and I want to measure the actual nursing costs. So that includes paid time off, that includes training, that includes temporary staffing. And so the way we want to look at cost productivity, the way we want to define cost productivity is solely by looking at an input measure, which is cost, and an output measure, which is volume. And so these are examples of input and output measures of cost per measurements that are used. So for nursing, it's nursing salary is the cost. And then what is the output, the med-surg days that are actually being created or served as a result of that nursing cost. And so you have to the far right the actual volume. In this example, the volume is going down by 1% from the prior year, but the expenses are going up by 2% versus the prior year. So were we productive? Well, our actual cost per med-surg day went up 3%. The next example is surgical services. You might argue, well, look, our expenses are at 0%. Our expenses did not go up. However, the actual number of OR hours went down by 1%. So again, our cost went up by 1%. So this is a way of actually tracking our productivity, not versus budget or not versus a standard, but comparing ourselves to past history. And then also we can compare ourselves to other facilities, to other physicians. So this allows multiple ways of looking at productivity. So these are some visuals around total cost productivity for a health system. To the top right is looking at, again, the individual areas, and it could be by facility, it could be by these different areas, whether it's nursing, whether it's the ORs, it could be your drug cost, your supply cost, or your actual physician cost per RVU. So this creates multiple opportunities to measure true productivity in a systemic way because of activity-based costing. And so this is a summary slide to talk about how to, what I say, win in today's environment and in the future. And I think the key is really on the right. It's about physician engagement. And the most important is the bottom right, having credible patient-level cost and quality data. And again, those indirect clinical costs are where the majority of your costs are. And it's where traditionally you lose the physician support by providing them this large nugget of allocated indirect costs. Well, here's the cost you were allocated for your OR time, for your labs, for your imaging, for your length of stay. And without some credibility behind it, you lose their support. And so what activity-based costing does is once it shows their consumption and it shows the cost that they've consumed, they look at it and they recognize their profile and they say, yes, that's me. That's my OR time. That's my length of stay. So they create the credibility that's needed to facilitate the rest of the things that you see around the circle. And so the last page is a bit of a sales page, and it's about course, but it's also about activity-based costing. So I would tell you there are three things, and I will argue with you if you say that these aren't true, because what they provide versus the other RVU-based systems, the RCC-based systems, the homegrown systems, is absolutely better analytics, 100% of your clinical costs showing where they've been consumed. The second or the middle, it's actually easier to implement and maintain than RVU-based systems and RCC-based systems. And it integrates very easily with visualization tools such as Tableau and ClickView. And then finally, from a value perspective, it is at a level which is, from a cost standpoint, either at the same price point or at a lower price point than you're spending today on your costing system. And this allows you, again, in a world where you're going to have to go out and negotiate prices with transparency around your procedures, it provides you with the correct data around true consumption, around true cost, to go out and negotiate with your payers to make sure you're being paid fairly, so that when some of your prices get commoditized, you're able to go out and negotiate higher price points for your premium services so that you are adequately and accurately paid. And so the rest of the slides, and I won't go through these, are just some visualizations and some examples of the kind of high-level analytics that are available through Chorus and through activity-based costing, where we don't want to be a finance organization that just generates reports, but rather we want to be a finance organization that generates things that the operators can use and the clinicians can use to make great and better decisions than they do today. Thank you.
Thank you, Rob, for that fantastic presentation. We also want to thank today's featured session sponsor, Health Catalyst. Thank you for joining us at Becker's CEO and CFO Virtual Forum, and enjoy the rest of your day.